Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. So in today's episode, I want to talk to you about postoperative wound management and more so for the outpatient setting. Especially nowadays with outpatient surgery and one-night hospital stays, I think many students, interns, residents, you don't really get a good exposure to what happens in those next few weeks as the wound is healing and maturing. So in the office, there's a lot of phone calls we get, a lot of nowadays pictures and photographs. Me personally and my staff know that, any of my patients in the early postoperative period, we just offer them an appointment. Hey, come in today if I'm in the office, or tomorrow if I'm in the office tomorrow. I like to see things because I find a lot of times, if it's nothing, patients really appreciate the fact that you just added them onto the schedule just to take a look at it, put their mind at ease. And if it is something small, usually if you catch it when it's early, you can fix it and address it. If you wait and just tell them, oh, just elevate it, ice it, a lot of times a small problem can turn into a disaster pretty quickly. So, that's the one thing I would recommend is, just see your patients, get them in, just take a peek at them. Don't just, tell them to elevate it or, put them on some antibiotics without seeing what's going on. So years ago, and I switched over probably 3 or 4 years ago, but years ago I used to use staples. And as much as we put staples in the hospital, in the operating room on a regular basis, patients hate staples. And occasionally you get these little staple abscesses. So it wasn't really on the incision itself, but you get these little pinholes where the actual staple goes on the medial lateral aspects of the incision. You get these little abscesses there. So it's really important just to kind of keep an eye on your patients if you're still using staples and make sure those areas stay clean. I always used to keep my patients wrapping their knee for the first 7 or 10 days after surgery if they had staples. So it was just kind of this area that I was always concerned about. And even when we were using staples, I would have patients come in and either myself or usually it was my nurse would actually take the staples out in our office because lo and behold, you'd have a home health nurse that would come in, or even the rare patient that, was old and sick and infirm and had to go to a nursing home. And, they just look at the schedule. Hey, staples are due to come out. They have no idea about whether or not is the wound looking mature. Are they diabetic? Are they malnourished? Maybe I should leave the staples in for another week. And if they're there, hey, the staples look bad. Maybe I should take them out at 10 days because they're looking red and erythematous. So, if you're using staples, definitely keep a close eye on those patients and make sure that you're monitoring them carefully. The other thing which, I've used and tried in the past, but I don't use is monocryl. Like a running monocryl does work well, but it is very operator dependent. So it does take time in the operating room, and you have to make sure that you're doing it correctly from side to side at the same depth, because if you screw up where you get, one flap high and one flap low, and you get this area of the skin that's not against one another, wait 2 or 3 weeks, that area is not going to heal and you're going to have this problem in wound drainage. So one of the ways I used to actually close it, the skin itself was, I would use a 2-0 interrupted Vicryl. And then when I switched over from staples, what I was actually using was a bead of dermabond and then full-length steries. And actually, it worked really well for a while. I get a little bit of drainage here or there in some patients, but for the most part, that worked really well. And then somebody turned me on to the idea of the Prineo dressing, which in my hands now is, I find it works great. I've been using it for over 3 years now, and the nice thing about it is it seals that wound off. And this way, I don't have patients cover it when they take a shower. And I extremely rarely see any blood or any drainage on the dressings. Occasionally, I'll get someone, the next day that has a little bit of, bleeding through the Prineo. But it's extremely, extremely rare. But with anything, there's always issues and problems. So when you put it on, it's really important to make sure that the knee is flexed because there is some stretch. But if you put it on in extension and then they try to flex, they're going to get a less shearing. And you have to be really cautious about patients that are apt or prone to swell, because like any adhesive, with shearing, those are the ones I believe are more at risk of developing little blisters. So you definitely want to control swelling. And then every so often, I get maybe one patient every couple months that gets these wicked rashes. I mean, it's very geographic. I don't know, is it from the liquid? Is it from the actual mesh? Is it a combination of both of those? I don't know. But, I do get some of these patients that have these wicked rashes. So when I see that, I've tried lots of combinations over the years. And what I find works really well is obviously, like I said before, all my patients with an issue, they come in. So they come in, we take it off, and they have just this rectangular, perfectly red rash-looking area. I usually put them on something non-sedating in the morning, like Zyrtec or Claritin, Benadryl in the evenings. And then what I'll usually use for dressings at that point is I'll just put steri strips over, because it's usually in the first week or so. So I need something in addition to the Vicryl. And then we keep a close eye on it. I've had one or two patients over the years that just wicked rash. Very, very bad. I'll do a little Medrol dose pack. But for the most part, if you get the bandage off, it usually clears up within a couple days. So those are all kind of the small things. The most common thing that you'll see, though, is going to be a stitch reaction or spitting a stitch. And it gets a little nerve-wracking, especially if you're in your first 6 months of practice. A patient calls your nurse and says, "Hey, I have pus coming out of my knee," and you're going to bug out. So I explain to patients in the preoperative information, and we use an app-based program that's set on a timeline. So, I have it keyed into the timeline right around about 3 weeks, and it just kind of informs them, hey, in the next few weeks, you may notice that you may spit a stitch or two. And what it'll look like right on the incision is a raised area, sort of looks like a pimple. You may get redness. You may get a little sort of vesicle-looking, fluid-filled sac. It may drain fluid, and it actually may drain dissolved stitch material that looks like pus. And if that's the case, call us, let us know. So, my typical sort of protocol is, if that does happen, again, we get a picture, offer them the option to come in, some form of triple antibiotic ointment, bacitracin, neosporin, something like that, 2 to 3 times a day. Stay out of pools, hot tubs in the meantime. Keep a small Band-Aid on it, and most of the time, those will resolve on their own. But it's important, and it's something to keep an eye on, because, if you notice, you're getting more of them, the question you have to ask is it how I'm putting in my Vicryl? I notice with certain people, certain rotations, hey, we get a little bit more for these 3 months and less for other 3 months. And sometimes it can be operator dependent. Sometimes it's just the patient. Some patients just, their body does not like the Vicryl. And it also has to deal, I think, a lot how many knots you're throwing and how deep those knots are. So try to bury the knots and only throw the number of knots that you need to secure the wound. But again, patient information is key. And letting patients know that it may happen before it happens puts their mind at ease, and then treat it, keep an eye on it. Now, the other thing, which is an issue that you're going to get a lot of phone calls about when you're out in practice, though, is drainage. My knee's draining. And again, that's another thing that just all of a sudden, gets you on edge, because what do you mean drainage? How much drainage? How long have they been draining? What does it look like? So again, have them come in. When they come in and it's a little bit of drainage, especially very early on, maybe it's bloody when they flex their knee, minimal concern. But if it's serious later on, if it's a high volume, that's where it gets concerning. So for me, the first thing I'm looking at, especially if it's bleeding and bloody, are they on anticoagulation? Are they on something, Eliquis, Coumadin, Lovenox, something else, Xarelto, even aspirin? But anytime that I have the ability to hold their anticoagulation for a few days due to bloody drainage and document that, I am holding their anticoagulation due to bleeding and wound complications, you're covered even if they do get a DVT or PE. You had a reason for what you did, but I'll usually hold the anticoagulation. The next thing too is, are they draining just because there's a rent between maybe one of the sutures? And if so, I always like to drain it. And sometimes you'll actually see the fluid in one of two spots. You can see it actually intra-articularly, and this is only by feel and evaluation and palpation. Or sometimes it can be subcuticular, sort of outside the capsule, and they'll get sort of this bloody effusion in this subcu tissue. So depending on where it is, I will aspirate it for 2 reasons. If I have a patient post-op that is draining, I am concerned about infection. And also, if they have fluid inside their knee that is putting pressure on the wound and it is causing that fluid to leak out, if I remove that fluid, I've decreased that effective volume pushing the fluid out, which may slow down or stop the oozing and bleeding and drainage, which should then allow the skin wound itself to heal. So I'll aspirate, send fluid off. And then again, for me, it's a judgment call of low risk, high risk. What does the fluid look like? Do I routinely put them on antibiotics or do I wait? It really is a case-by-case basis. But at least at this point, I've gotten a fluid sample. So if I've put them on an antibiotic, at least I had taken something out ahead of time. And then if it's negative, I can have them stop the antibiotic. The other thing that I'll do though too, and again, if it's a minimal amount of ooze, it just needs a little pressure dressing, great. So pressure dressing, lots of ice, more compression, more elevation, usually enough to slow down and stop a smaller scant amount. But if it's more significant, what I'll tend to do is if we stop the anticoagulation, aspirate their knee, wrap them up with a pressure dressing, actually put them in a small knee immobilizer for 72 hours, potentially more. And what you're doing effectively is letting the soft tissue calm down, letting that wound heal and start to knit. So this way, as they come out of the knee immobilizer, the wound is now sealed, so they're not going to drain anymore. The severe one that you want to worry about, though, is, and it's usually liver failure, or kidney disease, malnutrition, hopefully things that you picked up on prior to surgery and hopefully optimized prior to surgery. But that's where the incisional wound vacs can be helpful in placing those on. It was a lot more useful when I was doing big revisions with staples. Again, now with the Prineo, everything's sealed, so it's pretty rare that I see any drainage, but occasionally you can still get drainage, so you want to consider one of those incisional wound vacs. And you want to do your treatments early and aggressive. You don't want to delay and delay and delay, because every time fluid's coming out, stuff can get back in. So you want to make sure that that area is clean, and you want to stop that drainage as quickly as possible. So just things to kind of keep in mind, because again, in the operating room and in the hospital, you're kind of seeing patients at this small period of time. But as you get into clinic settings, and more importantly, when you get into practice, you need to understand that patients are going to spit stitches. Patients are going to have drainage, and you have to have a good understanding of where and why and when you're going to see them, how you're going to treat them, what you're going to do. And again, making sure that your staff have these algorithms. So if you're in the operating room, they can let the patient know, sure, yep, this is what we're going to do. You're going to come in tomorrow. Doctor's going to be in the office. In the meantime, stop the anticoagulation, and we're going to check everything out. But those are always really, really important things. And I think a great practice protocol, for every doctor, especially for young doctors, is any problem, question, post-op patient, just bring them in, set eyes on them. Even if it's nothing, those 5 minutes that you spend with the patient to look at them puts peace of mind in your head, but also means a lot to the patient that you took the time to see them, and you can catch something early. If they're spitting a stitch, have a protocol for how you're going to treat it. If they're draining, have a protocol for how you're going to treat it, and make a plan. In addition to those, drainage and send the fluid off, make a judgment call on, do you check additional labs? Me routinely, I usually do check a sed rate and CRP, because if I'm seeing them once, I hope that's the only time I see them in the postoperative period for a drainage issue. But if in a week or so, this is persisting and going on, at least I had a baseline sed rate CRP, and I can see, is that trending up or trending down at this point? It's just a useful and helpful bit of information. So have those protocols in mind, have a plan, have educational pieces that go out to the patient so they understand if something does happen, this is when it can happen and this is what we're going to do, but still have them inform you in the office. And this is really going to help you care for your patients and hopefully make a small postoperative issue a non-starter problem as far as leading to a big complication down the road. So thanks again for listening. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast, and I will talk to you next time. Thanks for listening. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.